Thank you, sir. Next, I invite Dr. Gopal Pillai to speak on mistakes that are committed when ophthalmologist examines the eye in systemic diseases.
Thank you very much, Srini. We'll start up with some stories. There was a 37-year-old female admitted with fever as well as decrease of vision, and there was this large mass-like lesion right on the center of the macula, and initial evaluation did not reveal anything. Manto was negative, there was a shift to left to lymphocytosis, X-ray tests were normal, and we were not getting anything. We waited, and then you can see that there was a large exudative retinal detachment. The case got progressed, and that is when we decided to take a needle and take a look at what we have, and then we got positive for tuberculosis. So in a case where there is an, in infections, when you are suspecting an infection, rather early in the course of the disease, I think we should get etiological proof, basically by using a paracentesis or by doing a vitreous biopsy. Now this was a case who came with just anterior uveitis, and it was treated with steroids, but a family history showed history of tuberculosis, and then his manto showed ulceration, and X-ray chest showed pulmonary tuberculosis. So just seeing the patient, seeing that there is a uveitis, you treat the uveitis with topical steroids, you may miss a lot of systemic issues as well. This is another patient who came with a DUSN type of picture with multiple retinal pigment epithelial mottling all over the fundus, and if we had missed this worm, the case would have been even more worse because the worm is live and will move all over the retina and would further increase the damage. Fortunately, this worm was picked out and was lasered out of that eye. Now, this is a patient who came with a typical optic neuritis, but there is a very subtle whitish retinitis here, which prompted us to look for toxoplasmosis. And so this is a toxoplasma optic neuritis. So if we had just pulsed, thinking that it is an optic neuritis, the toxoplasma may have spread elsewhere. From the optic nerve, it may have spread to the brain as well. So here the toxoplasma IgM was positive, and she was coming from an endemic population, and so anti-toxoplasma plus IV methylprednisolone was given. This is a 50-year-old gentleman with fever, mass in the throat, rashes, lymph node, palmar erythema, scalp rashes, etc. There was a biopsy taken from all these places. The mass, lymph node, all showed only inflammatory cells. A retinal examination showed something like this. So this was something like a candle wax drippings, and we were keeping on increasing the immunosuppression, and the patient was not responding. His fever was not going. Finally, we decided to poke inside and got a CMV positive. Then we got CMV positive from the blood. By that time, it was very late, and this patient succumbed. Now, this is again another HIV positive person who came with disc edema. It was shown elsewhere, and it was thought to be disc edema, and imaging of the brain was done. And this, if you look carefully, there are multiple satellite lesions here. This was actually mucormycosis, and this patient also had to succumb. So this is in a center where there are lots of transplants happening. A lot of patients are on immunosuppression. Now we very rarely see all those AIDS-related immunosuppressive problems because the heart treatment is now available. And so all these cytomegalovirus, herpes simplex, herpes zoster, TB, other mycobacteria, all those come. So sometimes, just on a routine evaluation, you saw this is on the nasal side. The patient did not have any symptoms. This is a cytomegalovirus retinitis, and you can see that after treatment, it just disappeared. And many of these sick patients who are having liver failure, etc., their immune status is so low that you have to look at the eye and evaluate it before you take him for further immunosuppression. Now, this is a good case to show that blood sugars should be well controlled before you take up for any procedure. She was having high blood sugars, about 350. When she was taken up for a Euro procedure, and 4 days later she reported with loss of vision. It is not an ophthalmologist's mistake, but you can see that there is fungal endophthalmitis in both sides. So this is what happens when we operate with high blood sugars. Sometimes the fungus from some place can actually lodge into the eye or elsewhere. And this was operated, and finally this patient is maintaining about 6/36. In endocrinology, diabetes is one of the major cause of referrals to our center. And mistakes in diabetes, one of the most major mistakes is poor diabetic control. Under and over injections and laser is quite possible. Cataract in the presence of DME and PDR, you do the cataract without actually addressing the DME or PDR, things can go worse. patient selection for retinal surgery, sometimes you operate, patient does not improve. Sometimes the patient who might improve, we do not operate. So patient selection is a very, very important thing, and mistakes can happen in that. And sometimes we can miss other end organ damages like nephropathy, etc. Thyroid, this is a patient who came with bilateral papilloedema, and actually this patient was having optic nerve compression, and then it had to be decompressed. Now, a subtle pallor of the eye, sometimes we may think that, okay, the discs are slightly pale, nothing to be done, 6/9, partial optic atrophy, but many a times we may miss pituitary adenoma in such a case. So even if there is a subtle pallor, you should definitely do a fields and consider doing an imaging. Hypertension is many a times confused with diabetic macular edema, because most of these patients may have hypertension as well as diabetes, and patients may come with a macular star, and one may think that it is diabetic macular edema, start injecting, etc. Whereas if you take the blood pressure, which is another omission that ophthalmologists generally do, we have to take a blood pressure, and sometimes the blood pressures may be as high as 240/140. Similarly, a papilloedema like this, you do imaging to look out at intracranial space occupying lesion. But if you don't take the blood pressure or look at the vessels carefully, you might actually miss a hypertensive retinopathy grade 4. This is another patient in whom I did a vitrectomy. Actually, after vitrectomy, I saw that there was a cherry red spot-like thing there, but then the visual acuity did not improve significantly. Only later could I understand that that is just a carotid insufficiency. The other eye, the fluorescence showed significant choroidal non-perfusion. Arterial blocks can actually come two ways. One is when you have time, so over 2 or 3 days slowly, like in an SLE, a thrombotic occlusion can occur, and this would be the picture that occurs like that. Or in the other situation, just like in an embolic stroke, you can have an embolus right here in circulation. You can see this is an embolus, and this is the infarction of the retina there. So this is thrombosis on one side and embolism on the other side, which can actually tell us what is a systemic condition, whether a thrombotic or embolic condition. We all would have heard stories of papilloedema where we missed something or the other. All of us would have stories of papilloedema like that. Now this is a patient with disc edema, unilateral disc edema, with a decrease of vision initially, but became all right. Actually, this patient moved out to become a multiple sclerosis. Now this is another patient in whom there was seizures and this particular appearance. You can see that there is a astrocytoma there, and so this is this is that syndrome. Okay, this is in a patient with PAH, a pregnant lady. She was referred to be having papilloedema, and she was thought of termination of pregnancy. But on closer examination, it's only the vessels which were dilated. The discs were completely normal. This was essential tortuosity of the retinal vessels, and we just observed her, and she became all right. Now, in the pulmonology side, sarcoidosis should be ruled out whenever we are having large areas of vasculitis, especially candle wax dripping type of vasculitis. Here you can see vasculitis all the way, almost all these vessels are vasculitis is there. So in these cases, you have to investigate. Manto will be generally negative. X-ray or CT chest will show the lymphadenitis, and you will not get, you may get granulomas, but non-caseating granulomas. So that is sarcoidosis. And sometimes this is again another case in which this was a granuloma-like lesion there, which with immunosuppression slowly disappeared. So over 2 years, this actually disappeared. We were initially confused about tuberculosis versus sarcoidosis. Finally came positive for, there was no tuberculosis. This is bare track pigmentation of the retina, and at this point of time, if we do not do an endoscopy, in some cases at least, this may actually show familial adenomatous polyposis, which is actually a pre-malignant lesion, and we may miss that. Subretinal hemorrhage, unexplained subretinal hemorrhage, we may have an idea, we may think that these are AMD, and we may consider injections. Actually, this is a patient with liver failure with clotting abnormality, which caused the submacular, subperipheral, subretinal hemorrhages. And in such cases, sometimes if you inject from the bleeding, that can bleed from the injection site also. You know that ROP, there are lots of mistakes, and any mistake that you commit in ROP will cost some 2 crore or 3 crore rupees as penalty. Rheumatoid arthritis, on treatment, sometimes, if you don't evaluate them properly, you may end up with something like this, chloroquine toxicity. A Wegners granulomatosis usually has a scleritis, and if you do not treat the scleritis with immunosuppression adequately, with topical steroids only, the final result may be something like this. There may be ciliary staphyloma, and significant damage can occur. Behçet's disease, so Behçet's disease, SLE, and these diseases they require immunosuppression from the start. Even if they present with only mild uveitis, they may require immunosuppression from the start. This is a case of lymphoma. On examination, it is very easy to examine this and say it is normal, and this may also be sometimes passed as normal, but seeing the difference in the hyperemia. So this was a patient in whom he had a cerebral extension of the lymphoma, and he was treated immediately with intrathecal, and then you can see the change in the, the hyperemia immediately came down in about 3 or 4 days. This is a central retinal artery occlusion in which the hemoglobin was about 18 to 19 hemoglobin. So polycythemia can cause something like this. Whenever you have bilateral bleeds, you should be thinking in terms of ITP or any other cause of thrombocytopenia. Here was a redness here. This was actually a sentinel blood vessel because of a tumor here. And this is treated with some topical steroids for some time. You lose precious time because this was a case of CA breast with secondaries in the ciliary body. Subtle pallor again. Yeah, this was a tumor inside. This is actually slight bulging of the conjunctiva. No topical steroid. This is basically lymphoma. This is salmon patch appearance here. So this was a case of lymphoma with creamy appearance in the retina, and this is the histopathology there. Sir has talked about retinoblastomas. I think my time is up. I think I should stop now. Thank you.
Thank you, Gopal, for that exhaustive presentation. The final talk of the day